Okay, so welcome everybody to this year, the 7th annual medical student teaching competition. So today we're gonna have 6 medical students come before you with an 8-minute lecture, and they're gonna be competing for the grand prize of $100. And we're gonna have a panel of Emory faculty that are gonna be judging to determine the winner. But as the audience, you're gonna wanna stick around to the end because we're gonna have a poll where you can cast your vote and be a part of helping to determine who the winner would be. So before we get started, we're just gonna have the judges just introduce themselves and tell you a little bit more about themselves. So we can start with Dr. Patisky.
Good evening, everybody. I'm glad to be here. I'm Don Batisky, member of the Department of Pediatrics. I'm a pediatric nephrologist. I'm also a small group advisor in the OSO Society. Good luck to all the contestants.
All right, thank you. Now we can go to Dr. Vatisse.
Hi, everybody. My name is Tracy Batiste. I'm a faculty member in the Division of General Medicine and Geriatrics at Grady Memorial Hospital, career-long clinician educator, former residency program director, hospitalist, palliative care doctor, and really happy to be here.
All right, Dr. Henry.
Hi, good evening, everyone. Dr. Tracy Henry, the other Tracy in the Department of General Medicine. I primarily do my clinical work at Grady, and my role in the School of Medicine is faculty student advisor and also impact program director. I'm happy to be here this evening. Good luck to everyone.
All right, Dr. Bonzo.
Sure, also very happy to be here. So I'm a hospitalist at Grady Memorial Hospital. I'm also a small group advisor and a clinical co-director of the MD-PhD program. Looking forward to seeing these presentations.
All right, and last but not least, Dr. Smith.
Hi, I'm Justin Smith. I'm a hospitalist at the Atlanta VA. I'm also an associate program director for Emory's Internal Medicine Residency Program and a member of the Emory School of Medicine Admissions Committee. I'm also a graduate of Emory School of Medicine. Joanna Bonsall and I graduated the same year, and happy to be joining this competition. Honored my 3rd year as a judge. Thank you.
All right, great. So we can jump right in, and the first contestant will be Zaynah Alam. So we'll just get her set up so that she can be able to set her screen in just 1 second and be able to start her presentation. Okay. So Zaynah, you should be able to share your screen, and then whenever you start speaking, your time will start. So just so everybody knows the rules, speakers are allowed 8 minutes, and if the speaker goes over 8 minutes, they'll be disqualified and not allowed to win. So just keep that in mind. But Zaynah, you can share your screen and you can start whenever you're ready.
Sounds good. Thanks so much, Malik, and thanks judges and everyone for being here. Go ahead and share. So you're on a long call day when you hear this happen overhead. Do-do-do-do-do, do-do-do-do-do. Code blue, room, your patient. Code blue, room, your patient. If you've been on the wards already, you know that means it's time to hit a stairwell and start running. So you get up to your patient's room and you find that their clinical exam is looking worse, their vital signs have deteriorated, and now your alarm bells are going off because you realize that your patient is in shock. What are you going to do? Well, first you have to be able to answer a few questions about what's going on with your patient. Namely, what kind of shock are they in, what's causing it, and what can you specifically give to make them better? The answer to these questions are going to be the subject of my talk, mechanisms of shock. So my main objectives are to make the pathophys of shock a little bit clearer, a little bit of a blast from the past from M1 and M2 year, and to make it easier to recall common causes and treatments for shock in a medical emergency. Most importantly, I want you all to stop feeling like this about shock. So first, a little bit about what shock is. It's an insult to the circulatory system that causes a state of tissue hypoxia. It often presents with hypotension, tachycardia, some of the other signs and symptoms we saw in our patient, and it is reversible, but only if you treat it fast. You've probably seen a table that looks something like this at some point in your medical education, and it can be a little bit daunting, and it would be quite boring for me to just walk through this line by line. So instead, I want to take us back to this scenario I showed earlier of 2 Nickelodeon protagonists with a very busy sushi conveyor belt. For some of our more experienced attendees in the crowd, I Love Lucy did something similar back in the day with a chocolate belt. So I want you to hold this image in your mind, and we're going to simplify things down a little bit. So here we have our two hard workers, Drake and Josh, or I Love Lucy and friends, who are here at the belt ready for a hard day of work. And then of course we have our input, our sushi that's gonna come flying in off the belt and needs to be processed by our hard workers to get where it needs to go. And finally, we have a very intrepid boss who's watching over all of the steps of this process and is going to step in and put some pressure on in the form of feedback if things aren't going the way they're supposed to. So let's jump right into ways. And so you can see that this really mirrors this cardiovascular system. You have an input in the form of preload, and you have your cardiac output in the form of your hard workers, and finally you have your afterload that can constrict or dilate accordingly as feedback to the rest of the system. So our area here is going to be what happens if there's not enough sushi on the belt. So here again we have our hard workers and they're braced and ready for that sushi to come flying at them, but instead it's more of a trickle. There's just not as much fish on the belt and not as much for them to do. So naturally they're going to get a little bit bored. One might get on their phone, one might wander off and go take a nap. They're just not doing the work they're supposed to be doing. And of course, in response to this, our boss is going to come barging in and start to put some pressure. So here our primary problem is that we don't have enough input coming into the system. With less to do, our hard workers aren't going to work as hard. And in response to this, our systemic feedback is going to start putting some extra pressure. This is how hypovolemic shock works. And you can think about anything that causes a loss of fluid in our system, like blood loss or burns, diarrhea, can cause hypovolemic shock. And the treatment to not having enough fluid is to give more fluid. Let's move on to our next scenario. What if instead of 2 workers, one of our guys decides not to come in one day? So now we have the same amount of input coming in, but we only have half the number of hands on the belt. So of course our poor worker is going to start to feel overwhelmed and our input is going to start building up. And when this happens, once again, our boss is barging in and wondering what the big deal is. So here, our primary problem is that our hard worker isn't working as hard as it's supposed to. In response to this, we see a buildup of input that can't be processed well enough. And again, our systemic feedback is going to come in and make some extra noise. So this is how cardiogenic shock works. Anything that affects the ability of our heart to pump blood along is going to cause cardiogenic shock. And one of the most classic treatments for this is an inotrope like dobutamine, something that can put a real kick in the heart's pants. So for our next scenario, I want you to imagine that there's now this barricade on the belt that didn't used to be there. So we have our input coming in and it's hitting this barricade and building up. But from the perspective of our 2 workers, there's really nothing here. So again, they feel like they don't have too much to do. They're not going to work as hard. And our boss is going to come back in and wonder what the big deal is. So here, from the perspective of our hard workers and the rest of the system, it seems like there's not enough input, even though really we know it's there and it's just getting caught by this barricade. In response to this, our hard workers aren't going to work as hard. And again, we're going to see our systemic feedback make some noise. This is how obstructive shock works. So here, instead of a primary problem with the heart itself, something like a pneumothorax or a tamponade is blocking the heart from filling up with input the way it's supposed to. And the treatment for this, of course, is to just relieve the obstruction. For our last scenario, I want to get a little bit topical. So it's March of 2020, and unfortunately, coronavirus has hit the conveyor belt. So it's early in the morning one day, and our poor boss has to come to terms with the fact that no one really wants to eat raw fish with their hands during a pandemic. So she decides to call off all of the sushi coming in and closes down shop. This leaves our 2 brothers caught up in the loop. And like many of the rest of us, they suddenly find they're stuck at home with a lot of free time on their hands. So they're going to do what a lot of us did and pick up a hobby, maybe another hobby, maybe too many hobbies, and start to feel really overwhelmed. So here, our primary problem is that we've lost our systemic feedback and subsequently lost our input. And with nothing left for our hard workers to do, they're going to kind of whip themselves up into a frenzy, trying to make up for that lost time and productivity. This is how distributive shock works, which is really overwhelmed by septic shock. But you can think about really any vasodilatory process, especially anaphylaxis or CNS injury, can lead to distributive shock. I also want you to remember, if you take away anything from this talk, that this is the one type of shock where you see a decrease in your afterload or your systemic feedback, and where your afterload is the primary problem. And the treatment for too much vasodilation is vasoconstriction. So think about pressors here. So we've now walked through every single component of this table, and hopefully, instead of seeing a bunch of arrows and getting a little bit confused, you can instead remember some of these scenarios that we talked about, and you'll be able to remember them in emergency and help your patient feel all better. Thank you so much.
I think that was really good. Okay, so the next speaker that we'll have is Christopher Arthur.
Okay, hey everybody.
All right, so yeah, and then whenever you start speaking, when your time will start.
Okay. All right. Okay, hey everybody. I'm excited to be here. So I'm going to be talking about psychedelic drugs and their utility in psychiatry. So to begin, I want you to imagine that you're in a boat and you're cruising along when suddenly you hear a loud crunch and your boat begins to fill with water. Well, thinking quickly, you grab your trusty bucket and continuously bail the water out until you safely make it to shore. But what if this hole had been larger, such that no matter how quickly you bail the water out, the level just continues to rise? Clearly, the approach that you were taking before and that worked before isn't sufficient in this current situation. Unless you find yourself at the bottom of the ocean, what you need is an entirely new approach, one that can allow you to go deeper and address the root of the problem. In psychiatry, there's a well-established approach to treatment that involves psychotherapy with long-term and often lifelong use of medication, along with all of the adverse effects that brings. To medical students, this paradigm is so well established that it's often taken as dogma. But while a combination of cognitive behavioral therapy and an SSRI is practically always the correct answer in a standardized exam, we know that in real patients, there's a significant proportion that are left out of this equation. In these results from the largest trial ever on depression treatment, we can see that only about half of patients will achieve complete resolution of their symptoms with up to 2 different antidepressants. And that number only rises to about 2/3 with up to 4 different treatments. Like, while this is all going on, the number of side effects increases exponentially as you add each treatment step. So all of this is to say that for many, the approach we have just is not working. So what I want to accomplish with this presentation is to introduce a new paradigm that's being developed in psychiatry. One in which a group of hallucinogenic serotonin 2A agonists, better known as hallucinogenic drugs, can be used to take a new approach to the treatment of mental illness. This approach doesn't require ongoing use of medications, but instead can be used deliberately and sparingly in a therapeutic setting to produce transformative experiences, such as new insights and perspective changes, or an increased willingness to engage with traumatic memories during a therapy session. These experiences, experienced in the altered state, can then be intensively processed during psychotherapy to try and catalyze therapeutic breakthroughs and ultimately lead to sustained remission of disease. Now, this is a controversial subject, so I think it's important to understand how we got here. In the 1950s, before psychedelic drugs ever even entered pop culture, they were already being recognized and used by psychiatrists for research and clinical practice. Later in the 1960s, the socio-political landscape began to shift, and ultimately in 1970, with the passage of the Controlled Substance Act, these drugs became Schedule I narcotics, leading to a 25-year hiatus in all psychedelic drug research. It wasn't then until the 1990s that we saw some small studies begin to pop up again. And finally, in 2016, we had the first large randomized clinical trials involving psychedelic drugs. And so these 2 seminal trials from 2016, coming out of Johns Hopkins and NYU, were remarkably similar in their design. They were both double-blind, placebo-controlled crossover studies that were investigating psilocybin, the psychoactive component in magic mushrooms, as a treatment for anxiety and depression in patients with life-threatening cancer. So they took patients with depression and cancer and randomized them into one of 2 groups. In the context of intensive psychotherapy sessions, the first group received a dose of psilocybin, while the second received the placebo. They were measured for anxiety and depression some weeks later, and after that, the treatment groups were crossed over and the pattern repeated, ending the 6-month follow-up. And what these researchers found was that in the group that received psilocybin, shown here in red, they had significantly greater remission from their depression after 5 weeks compared to the group that received the placebo here in blue. And not only that, but the group that received psilocybin, that percentage of patients achieving remission did not diminish as far as 6 months after the initial trial, despite not having received another dose of the drug. The Johns Hopkins study found this wasn't just true for depression, but it was true for anxiety as well. And perhaps most importantly, these results were independently replicated by the NYU study, providing the most solid evidence at the time for the therapeutic benefit of a psychedelic drug in psychiatry. And so what about safety? Well, these trials found no lasting adverse effects, either medically or psychiatrically, which builds upon nearly 3 decades of studies involving psilocybin. And regarding one of the most common concerns with these drugs, evidence does not support a link between the use of psychedelic drugs and an increased rate of mental illness. So as exciting as these results are, they certainly are not without limitations. The sample sizes of about 56 in the Johns Hopkins study and 29 in the NYU study are quite small compared to most pharmaceutical trials. And there is a problem of trying to blind participants and researchers to the treatment drug with something as psychoactive as psilocybin. But while future research is certainly still needed, we can see from the studies that have been done that the potential impact of this research is expansive. In addition to anxiety and depression, psilocybin shows promise with disorders such as OCD or substance use disorder, which have been historically very difficult to treat. And while I focused on psilocybin in this talk, there's been recent evidence from clinical trials involving MDMA for the treatment of PTSD that shows similar promise. So in summary, psychedelic drugs offer an exciting potential to usher in a new paradigm in the treatment of mental illness. This new approach has intriguing evidence for sustained longitudinal benefit without the use of a lifetime of aversive medications. All of that weighed against a remarkable safety profile. Clearly, this paradigm is a promising option for future psychiatric treatment. And so, if you ever find yourself in the middle of the ocean with a problem that you can't solve, don't be afraid to take a breath and try a new approach. Thank you.
All right. Yeah, before we move on, actually, I'm supposed to give you an opportunity, like if any judges have any questions or if any of the audience has any questions, you can type it in the chat so that Christopher can respond if there are any questions. Okay. So the next person we have, David Gibbs. Oh, we also have to do the same thing for Zaynah, the first speaker actually. So we're going to bring Zaynah back. So like if anybody had any judges or any of the audience had any questions for Zaynah's talk, you can like type it in the chat also. All right. So the next speaker we have is David Gibbs. All right.
Hi, everyone.
So you should be able to share your screen and everything.
All right. All right. Can you see it okay?
Everything's good.
All right. Well, I'll get started then. Hi, everyone. My name is David. I'm in the MD PhD program, and I just finished my PhD in epidemiology. So I wanted to talk today about one of epidemiologists' favorite words, risk. What is it, and why is it so important to understand, particularly now in the midst of COVID, but also clinically? And specifically, I'm going to talk about three important aspects of risk that are commonly misinterpreted or ignored. And these are the denominator, the type of risk, and bias. So what is risk? Well, if you type it into Google, this image comes up. But how risky are roller coasters, and how do we quantify that? So which of these do you think leads to the most hospital visits in the US each year? So I'll give you a minute, well, not a minute because I don't have that long, but a second to read through these. Come up with your answer. All right, well, the correct answer is cats. So according to the CDC, cats is number one on this list. And actually more people go to the hospital each year in the US for roller coaster related injuries than aortic dissections and giardia combined. So why are we learning so much more about these things in medical school? Well, that brings me to my first lesson, which is that risk is really all about the denominator. Because in epidemiology, risk is not the number of events, but the probability or the chance of an event in a given at-risk population. So the number of people who go to the hospital after being bit by their cat isn't very meaningful if we don't know how many people were bit by a cat or were at risk of going to the hospital. So if we take the number of hospital visits and divide by the number of people who were exposed to each of these things, you can see that we get a much different picture. So while aortic dissections, fortunately, are quite rare, over 90% of people who do have an aortic dissection end up in the hospital in the US each year, compared to 0.0005% of people who ride a roller coaster. So how is this relevant to COVID? Well, many of you may have seen an image such as this, indicating that the United States is still dominating the world in terms of number of COVID cases. But does anybody know which country's citizens have had the highest risk of COVID positive cases to date? So the answer, formulated in your mind, and it actually surprised me, was Chile. And I think this is really important because Chile has definitely not been dominating the news headlines that I've been reading, but it's important because a greater proportion of Chilean citizens compared to anywhere else in the world have had the highest, the risk of COVID. And yet the news continues to be kind of obsessed with just what country and what state has the number of cases, which epidemiologists would argue really isn't meaningful in terms of risk. But there's another important aspect of risk, which is that it comes in different types. So up until now, we've been talking about absolute risk, or the risk or probability of an event in one group, but we can also compare risk in two groups and talk about relative risk. And I think this is important because clinically and in the news headlines, we're often given kind of vague statements like COVID-19 frontline healthcare workers at risk of mental health problems, or so has a high risk of suicide, but is that an absolute risk? Is it a relative risk? And why does it matter? So that particular article was based on a study in JAMA, which found that relative to non-frontline workers, so who were seeing COVID positive patients, were at a higher risk of developing symptoms of depression and insomnia. So I think it's quite intuitive to see these different risk ratios and conclude that frontline healthcare workers are at a higher risk of insomnia than depression, right? But that would actually be wrong because we're confusing relative and absolute risk. So what this study actually found was that frontline workers were at a higher risk of insomnia relative to non-frontline workers, but they were actually at a higher absolute risk of depression. In other words, they were more likely to become depressed throughout the study than they were to develop insomnia. So the take-home point here is that relative risk or odds ratios or anything on the relative scale really tells you nothing about how likely a disease is in a given group. And this is important because this is often what we may be interested in clinically. So if so-and-so has all of the risk factors for suicide, that doesn't tell us how likely they are to commit suicide, which may impact how often we want to follow up with them, etc. And then the last thing I wanted to touch on is that we have to watch out for bias. Because in epidemiology, it's difficult, if not impossible, to estimate things perfectly. So going through all the types of bias is well beyond the scope of this study, but 3 specific types that I wanted to touch upon that I always think about when I read articles. One is information bias. So this could be a coding error or misclassification in our event or our exposure. So I think about wrong numbers being analyzed. There can also be confounding or the mixing or confusion of effects due to extraneous third variables. So in the previous example, what if frontline workers were older and older individuals were more likely to develop depression or insomnia? And also selection bias, which can arise due to differences between the study participants and the non-participants. So what if non-participants in that study, for example, were happier, less interested in participating in a study about mental health outcomes, and may also be less likely to be on the front line, then this could bias our risk estimates. So the take home here is that a lot of things can go wrong in the process of estimating risk. Hopefully it was a good study that minimized the sources of bias, but regardless, we must be cautious and critical, and I think it's important to communicate this cautiousness to patients. So on that note, lessons, I think, for clinical practice specifically, just because something is common does not mean there is a high risk, and vice versa. There's also different types of risk, which can be important, but for different things. So relative risk, which is often what abstracts and up-to-date focus on, can help us understand disease etiology or risk factors. But it's really the absolute risk that often patients are interested in. So just because I have a risk factor, how likely am I to get this disease? It can help us prioritize public health resources and screening. And the last and probably most important lesson, I think, is that there's error in these estimates. So even if it's published in the New England Journal of Medicine and it's a huge randomized clinical trial, it does not mean it's perfect. We have to take it critically and think about what may be affecting that estimate. So in summary, hopefully through this presentation, you've learned that risk is not just a numerator, but a denominator. It comes in different types, which can be important for different reasons. And it can be, or even usually is, biased. So we have to be cautious and critical about our risk and how we communicate that to patients. So thank you very much.
All right, I think that was really good. So if any judges have any questions, you can unmute yourself and ask. And for everybody in the audience, you can also type in any questions if you have any for David. All right, so our next speaker will be Michaela Henderson.
Great. Thanks, Malik.
All
Hi,
right, no
everyone.
problem. All right, and you can start whenever you're ready.
Great. So today I'll be talking about the hemoglobin oxygen dissociation curve and its clinical relevance. So just a quick outline, we're going to start by reviewing the cooperative hemoglobin oxygen binding curve, talk about what can shift this curve either left or right, and then end with a clinical case. So here is the hemoglobin oxygen dissociation curve, and just as an orientation, the y-axis is % oxygen saturation of hemoglobin. So this is just saying of all the available oxygen binding sites on hemoglobin, how many of those are actively bound by oxygen. So this curve is showing us for any given partial pressure of oxygen in the blood, what is the expected % oxygen saturation. So the first thing you may notice about this curve is that it is nonlinear. The shape is actually considered sigmoidal. So what's giving this curve the sigmoidal shape is a very interesting property of hemoglobin called cooperative binding. And this property is very essential for what makes hemoglobin so good at delivering oxygen from the lungs to the tissues in the body. So we're going to dive into this property a little bit more. So what is cooperative binding? hemoglobin molecules each have 4 binding sites for oxygen. And this property of cooperative binding effectively means that when a hemoglobin molecule is in an environment with a lot of oxygen, it's really good at binding oxygen. But when it moves to an environment with lower concentrations of oxygen, it is less effective and kicks off these oxygen molecules. So in order to kind of conceptualize and remember this, I like to think of the surrounding oxygen molecules as cooperative kindergartners who like to play follow the leader. So if this hemoglobin molecule is in an environment with lots of oxygen around, one of these cooperative kindergartners is going to get bored and hop on. And this makes it subsequently easier for everyone else playing follow the leader to hop on after him. And soon enough, we have a full hemoglobin molecule. But when this molecule travels to an environment with lower concentrations of surrounding oxygen, one of these kindergartners is probably going to wander off, and in their follow the leader fashion, the other 3 are going to hop right off after him, leaving an empty molecule. So what this means in terms of the body and the overall curve we just saw, when hemoglobin is in the lungs with lots of these cooperative kindergartner oxygen molecules, it's really effective at binding oxygen. You can see it's about 100% saturated. But as it moves in the body and moves towards the systemic veins and tissues that have lower concentrations of oxygen, we see this sharp dip in the curve, and hemoglobin starts kicking off all these oxygen molecules. And that's what makes it so good at delivering oxygen from the lungs to the tissues. We can see this big drop of about 25% of saturation. So all those molecules are being delivered to the tissue. So now that we understand the overall shape of the curve, we can talk about what can shift the curve either left or right. Now, what exactly does it mean to have a curve shift? So if you shift the curve to the right, you can see here that it's actually delivering more oxygen to the tissues. So as compared to the normal 70% at tissue level, it's now down to about 50% saturation. So extra oxygen has been kicked off the molecule and given to the tissue. But if you shift the curve to the left, you have essentially the opposite reaction. Hemoglobin becomes less effective at delivering this oxygen to the tissues, and you can see that it's still saturated at about 80% at tissue levels of oxygen. So what will shift this curve to the right? So as I previously said, shifting the curve to the right will deliver more oxygen. So what are some of the states that your body can be in where it needs more oxygen? Effectively, anytime your body is under any sort of stress. So if you have an infection, you're in sepsis, if you're even just exercising, maybe at a high altitude, all of these things require more oxygen to your tissues. And hemoglobin is actually really smart and can pick up on these kind of molecular signals that your body sends to it, telling it to make this adjustment. So what are these signals? I like to remember them with the mnemonic ACE bat. So I picture a right-handed batter named Ace, and he's really good, so he knocks it apart. And the crowd jumps to their feet. This reminds me that all these values are increasing. So what does ACE stand for? An increased amount of acid, carbon dioxide, or exercise. When you're undergoing higher levels of metabolism, you produce more carbon dioxide, which your body then converts to acid for transportation. So that's why we see an increase of these when we're in states that we need more oxygen. And BAT stands for 2,3-BPG, which is a byproduct of glycolysis, increased altitude, which just has to deal with the lower amounts of oxygen in the air. So our bodies need to be more efficient with any oxygen that we already have. And increased temperature, which can similarly be seen in states of stress or exercise. So now that we understand what shifts it to the right, what shifts it to the left is pretty easy to understand because it's just the opposite. So any decreases in those ACE-BAT values. So ACE-BAT is all well and good for step 1, but how is this actually clinically relevant? So the molecular mechanism is actually really relevant to a lot of disease presentations, but I just wanted to go through a case to really hammer home some of these points today. So here we go. A 38-year-old man with no significant past medical history presents to the ED with acute onset shortness of breath, nausea, headache, and dizziness. His lips and fingertips are a bright cherry red color. He just finished a double shift at his job as a parking attendant in an underground garage. So these signs, symptoms, and history are all very indicative of carbon monoxide poisoning. So what's going on here at a molecular level? Carbon monoxide binds to hemoglobin with about 200 times the affinity that oxygen does. And carbon monoxide is a molecule that can be produced by cars or fire, hence his clinical history. So basically with this tight affinity for hemoglobin, we're seeing a dramatic upward shift of the curve. And you can see that the hemoglobin has very little difference in saturation from the lungs to the tissues. So the tissues aren't receiving very much oxygen, and the effects of hypoxia on these various organ systems are getting the symptoms that we're seeing, such as headache, nausea, shortness of breath, dizziness, and the cherry red color, which is the color of carbon monoxide bound hemoglobin. So how do we treat this? We give 100% hyperbaric oxygen to the patient. This is essentially increasing the concentrations of oxygen in your blood to such a degree that they're now able to kind of kick off those molecules of carbon monoxide and rebind to hemoglobin. So we're taking this strongly leftward shifted curve and resetting it to normal, where there is a significant difference in oxygen saturation from the lungs to the tissue so that the tissues can receive those molecules of oxygen. So in summary, hemoglobin displays cooperative kindergartner binding, an increase in ASPAT shifts the curve to the right, and we treat carbon monoxide poisoning with hyperbaric oxygen. And that's it. Just wanted to thank the MSTC and the judges and my two mentors.
All right, I think that was really, really good. So if any judges have any questions, or if any audience members have any questions for Michaela, you can type them in the chat, or for the judges, you can unmute yourself. Okay, so I'll just wait a couple more seconds just to see if there's some questions. Okay, so the next speaker will be Dan Rzewnicki. All right.
Okay, so p-values are an important metric that we use to evaluate study results, and we also use them to make a lot of decisions about clinical practice. One thing that we've had to think a lot about lately is how to treat COVID patients. And one study that's had an enormous impact on the treatment of COVID patients is the recovery trial, which is a randomized controlled trial of various treatments for COVID, one of which was dexamethasone. So if you're like me trying to learn about this study, you might have a bad habit of skipping straight to the results section and immediately scanning for p-values just in search of small numbers. But I want to take a little bit of a closer look at what these small numbers actually mean. I want you to understand what p-values are, what they're not, and how we can use confidence intervals for more information. So in this study, they're going to take the mortality in the dexamethasone group and that in the control group and see whether or not those two things are equal. And they'll start with some hypotheses. Their null hypothesis will be that the mortality in those two groups is equal, and alternatively, they'll hypothesize that those two groups are not equal. And visually, that looks like this. Where in their null hypothesis, they're assuming that the mortality in the control group perfectly overlies that of the dexamethasone group. And alternatively, they'll hypothesize that those groups do not perfectly overlap, that there's some difference between them. So statistics is all about gathering evidence to either accept or reject that null hypothesis. So how do we do that? Well, we start by assuming that there's some underlying population of all COVID patients that has some average mortality rate. And that average is the center of a normal distribution that has some standard deviation. And because it's impractical to measure the entire population, we're going to sample from that population to generate a sample mean, which is an estimate of our population mean. Each time we repeat the sampling process, we'll generate a slightly different sample mean. And the difference between those sample means is what we call sampling error, and it occurs purely due to chance. We also assume that if we sample from this underlying population an infinite number of times and plotted the sample mean that we got each time, we could construct the sampling distribution. And the sampling distribution, it turns out, is also a normal distribution, and it has the same mean and standard deviation as the underlying population. So we can use the information that we know about the sampling distribution, as well as what we know about normal curves, such as where standard deviations fall in relation to the mean, and the likelihood of observing particular sample means to make inferences about the population. So we know that if we sample from this population an infinite number of times, 95% of the time, our sample means will fall between these 2 points of plus or minus 2 standard deviations from the mean. And we also know that outliers beyond those points are pretty unlikely. There's only a 5% chance of seeing sample means beyond those points. So when we do see those outliers, we're going to assume that they must not have come from this underlying population. They must have come from a population that was centered around a different population mean. So to return to our example, the mortality in the dexamethasone group was 22.9%, and it was 25.7% in the control. And that gave them a p-value that was less than 0.001. So that means that if the mortality rate in the control group really was equal to that of the dexamethasone group, there would only be a 0.1% chance of observing a sample mean as low as what they saw in the dexamethasone sample. And since that's super unlikely, even less than a 5% chance, they are going to assume that that sample of dexamethasone patients did not come from that underlying population. It must have come from a population that's centered around a different mean. But let's return to this slide for a second and imagine that purely due to chance, we sampled only from this lower tail of the curve. Well, that would give us a really low sample mean, even lower than what we saw in the dexamethasone study. So since the sample is so low and there's such a small likelihood of observing it, you would conclude that that sample must not have come from this underlying population, even though it did. So p-value does not prove that the alternative hypothesis is true because we can never know which sample means occurred purely due to chance or due to sampling error. And p-value only tells us the likelihood of observing a particular sample mean if the null hypothesis is true. So no matter how small the p-value, we can never be certain that our results are not due to chance. P-value also does not provide any information about the effect size. And effect size is a measure of the magnitude of the difference between the groups. When these two groups are relatively far apart, we call that a large effect size. These two groups are closer together, we call that a small effect size. So returning to this example, there was a 10.9% decrease in mortality between these two groups. And contrast that to the study of remdesivir for COVID patients, where in one of their subgroups, they found a mortality of 1.8% in the control group, or in the remdesivir group, and a 9.5% mortality rate in the control group. But that gave them a p-value that was greater than 0.05, so it was larger than what they saw in the dexamethasone study. However, there was an 81% decrease in mortality between these two groups. So in the dexamethasone study, there was a very small p-value, but a relatively smaller effect size. In the remdesivir study, there was a relatively larger p-value, but also a relatively larger effect size. So smaller p-value does not mean that there's a greater difference between the two groups, and it also doesn't necessarily mean that the difference that you're observing is clinically significant. So who cares? Why does this matter? Well, it matters because p-values are poorly understood, not very reproducible, and they don't provide much information about the underlying population. Confidence intervals, on the other hand, can actually give us some information about the underlying population. So if we return to this slide for a moment, we remember that we can use information about the sampling distribution as well as information that we know about normal curves to make inferences about the population. So we can take our sample mean and our sample standard error and construct a confidence interval, which is a range of values in which the true or population mean is very likely to lie. So if we take a look at this table and try to train our eyes to, instead of just focusing on the p-value, to also take a look at the confidence interval, we find that in this study, the confidence interval was between 0.75 and 0.93, which we interpret as meaning that they are 95% confident that the true mortality risk is between 25% lower and 7% lower in the dexamethasone group compared to the control. And that gives us a ton of useful information. It tells us where the actual population parameter might lie if we could measure the entire population. And it also gives us an idea of the precision of their results, where the more narrow the confidence interval, the more confident we are that they've generated a precise estimate. And contrast that with this study that I presented at the American Thoracic Society conference, where I said that electronic cigarette use was related to 9.7 times higher odds of having a DLCO below the predicted value. Our p-value was pretty low, it was 0.008, but our confidence interval was incredibly wide. It was between 1.9 and 52.1. So even though we had a really low p-value, we didn't have a very precise estimate of our effect. So to recap, p-value gives the likelihood that the observed result would occur if the null hypothesis was true. Detecting a statistically significant p-value does not tell us about the alternative hypothesis, the effect size, or the importance of the study. And confidence intervals are a useful tool to further evaluate and contextualize study findings. Thanks to my mentors for helping this talk, and thanks for listening.
All right, and if any of the judges have any questions or any audience members, you can type them in the chat. All right, and so now we can get ready for our last speaker for tonight, Rebecca Steinberg.
Let me share my screen. Okay. Have you ever taken your cat on a long car ride only to find that the first poop at your destination is pure liquid? Or maybe you've taken an important test like step 2 CK and felt your bowels kind of tugging away at your focus halfway through the first block. What about being trapped at home during a global pandemic and you start to know your bowel regimen's kind of getting out of whack? I think many of us are familiar with the sensation of mental strain manifesting in mysterious ways, but often people are afraid to talk about how downright dirty things can get. Poop problems are important, not just for each of us personally, but in helping our patients understand something that has historically been considered shameful or taboo. Hi everyone, my name is Rebecca Stein and I'm a 4th year medical student, and today I'll be presenting on the relationship between stress and pooping through the condition irritable bowel syndrome. So today we'll be talking about what IBS is, 2 theories for what causes IBS, and then possible treatment options for our patients. Now for my talk, I wanted to focus on irritable bowel syndrome, which in an oversimplified way could be considered a diagnosis of stress pooping. That said, this is a very serious condition for our patients, as the presence of the disease itself can be distressing and frustrating on a daily basis. So IBS is a functional disorder of the GI tract with a normal colon that is misbehaving. And all the subtypes are characterized by chronic abdominal pain and altered bowel habits, often relieved with defecation. The subtypes are classified by stool pattern, whether that be constipation, diarrhea, a mixed presentation of the two, or unspecified if a patient's symptoms don't fit into a specific category. And this condition has also been found to be more common in young patients and women. So there are many contributing factors to IBS, and many of them take on a chicken or the egg narrative. For example, it's hard to tell whether food sensitivity is a consequence of IBS or the cause. Interestingly enough, a history of abuse has specifically been studied as a contributing factor to IBS, which is why it's listed here as a separate factor from psychological stress. Today, I want to talk about 2 theories for IBS, the impact of psychological stress on the gut and the microbiome. So it's been well established in the literature that there's a bidirectional brain-gut relationship, and this relationship is mediated by 2 systems, the hormonal HPA axis and the autonomic nervous system. And the details of these pathways and how they integrate with other regulatory systems is extremely complex. But on a big picture level, the HPA axis starts with CRF released from the brain in response to a stressor, eventually generating its effector hormone cortisol. Feedback from the gut regarding bowel distress can occur in parts of the brain responsible for emotions and memory. The second pathway is the autonomic nervous system, which is responsible for our fight or flight response. And the ANS works in collaboration with the central nervous system in the brain and the enteric nervous system in the gut. Overall, stress can cause the gut to upregulate certain immune cells, alter its motility to slow down or speed up, increase organ perception, as is very characteristic in our IBS patients, increase intestinal secretion and permeability, and alter the contents of the microbiome itself. But before we add the microbiome as a component in this equation, I want to establish what the microbiome is and what we know about its potential and composition. So the microbiome is defined by microbial communities in the gut and the environment that they inhabit. pathogenic and symbiotic bugs can coexist without major problems in a healthy individual. Actions of this community that help their human hosts include fermentation of starches that lead to downstream anti-inflammatory effects and even anti-tumor activity, drug metabolism, conversion of bile acids, and colonization resistance. And we can see how important this last point is when we think about how antibiotics can wipe out local gut flora and overtake the gut with C. diff. This microscopic community has been shown to have influences on many disease processes, from autoimmune inheritance to obesity to allergy development. Remember these pathways? Let's dig down deeper by adding the microbiome to the mix. So we can see a good deal of overlap between many of the relationships we've already discussed. From the brain, the microbiome is influenced by local changes, such as mucus production, gut motility, intestinal permeability, and immune regulation. But the microbiome also influences the brain, possibly through modulation of the HPA axis set point, generation of signaling molecules like neurotransmitters, and then local effects on the gut, which translate back to the brain. One study I found particularly embodies this bidirectionality. This study by De Palma and others took stool samples from healthy and IBS subtype D donors and transplanted them into recipient germ-free mice. They monitored several changes in the mice, from gene expression to behavioral changes, and they found that mice with the fecal transplant from IBS positive patients were more likely to have increased gut motility, altered permeability to their intestinal barrier, increased anxiety behavior, increased cytokine production, and different metabolic profiles compared to mice transplanted with healthy donor stool samples. So what can we do with this information? Well, the treatment strategies for IBS have as wide a range as its etiologies, and so most patients have to try several strategies that best suit their specific situation. Some will try altering the environment in their gut through changes in their diet. Many patients are prescribed exercise as a way to regulate bowel function, particularly if they have the constipation subtype. Pharmacologic therapies of the gut can increase or decrease gut motility, but also come with side effects and risks of their own. And then notably, psychologic therapies such as antidepressants and CBT have shown efficacy in managing IBS. But one treatment possibility that has started to be explored is transplantation of fecal microbiota from healthy individuals to those affected by IBS. So the idea of FMT is both brilliant and disgusting. And while this therapy is not currently being employed for IBS, we can predict its efficacy based on trials of FMT and resistant C. diff infection. Patients who received FMT had a greater than 90% cure rate of their C. diff in a matter of hours to days after transplant with very few adverse events. And these patients may even require only one treatment in order to be cured. We saw in the IBS study in mice how transmission of poop can also transfer anxiety and other bad attributes to recipients. So this therapy should be given with caution. The immediate risks in fecal transplant include infection and GI comorbidities. Interestingly enough, men might be preferred over women as donors because they're less likely to have risk factors for IBS. But there may also be potential for side effects from FMT years down the line. And the long-term side effects are still not fully understood, but animal studies have shown possible increased risk for transmitting risk factors for obesity, diabetes, atherosclerosis, and even colon cancer from donor to recipient. So I hope today you've learned that there are many contributing and collaborative etiologies for IBS, that the stress axis is an important contributor to gut function, that there may be interactions between stress and the composition of the microbiome that contribute to the clinical picture of IBS, and that fecal transplant might be a viable option for these patients in the future. Clearly, the relationship between the gut, brain, and GI bugs is intricate and still not fully defined, and there's a lot of room for growth in exploring this interplay of macro, micro, and psychosocial factors. And thank you to everyone who helped me out with this presentation.
All right, that was really good. So if anybody has any questions, you can type them in the chat, or any judges have any questions, you can ask Rebecca at this time. Okay. Or if anybody has any questions about any of the other presentations that have gone before, you can type them at this time if you would like. Okay, so we have the results are in, and the official winner for both the judge vote and the popular vote is Zaynah Alam. So the grand prize is $100, so you get that and an award on your resume. So that's great. So congratulations.
Thank you guys so much.
And I know that Dr. Manning is here. I don't know if you wanted to have any closing remarks for the event, Dr. Manning. If you did have any closing remarks, you can like unmute yourself if you want to.
Oh my goodness. Hi, everybody. Well, I will tell you guys that when you become a full professor and a mom whose kids are starting school virtually and who works on a podcast with a deadline tomorrow, that you can sometimes miss being where you're supposed to be. I apologize for missing everybody's wonderful presentations. And one of the things I was asked to talk to you guys about was, and I'll keep it brief, was about the power of anyone teaching and also of bite-sized teaching in a short clip. And I think what you already learned and what I learned from coming on at this time and all the talks being over is that you can pack in a lot of teaching in a short period of time. And things that we always like to think about are, what is the topic that you're talking about? Make sure that it's narrow enough, that you don't try to teach too many things at once. Pick 2 or 3 teaching points and teach them well. That's really important. And then you don't always have to be super fancy about it either. Just really get to the point and dig deep and teach the points that you have, teach them well. And ultimately, people can walk away not just looking at you thinking you're smart, but actually having something that they know, something that they learned that they can apply. And so there's so many students on this call, and you teach your learning objectives on your modules regularly. I challenge you all to be inspired by what you saw today and really push yourselves to that next level when you're doing the learning objectives. Don't just, make a little outline or something like that. Really probe people to think deeper, to have something they can walk away with. So just keeping that in mind, that's really one of the main things I wanted to say. And we're excited about our spirit of everyone teaching, not just faculty, but everyone. It elevates the entire institution and makes us look for more and pushes us as faculty to do a better job. Congratulations to all the participants and congratulations to the winner. I see that it's being recorded, so I can't wait to hear it.
Awesome, awesome. So do any of the other faculty that are on this Zoom have anything to add before we end the event?
Thanks to everybody who participated. It was fun watching.
Yeah, wonderful job, everyone. I always learn so much from all of you. Thank you.
And kudos for taking this on with the added challenge of adapting to the Zoom format. That was fantastic.
Yeah, congrats to all of you. You all kept me engaged and I learned a lot.
All right, so I think that's all. So thank you everybody for coming out. So we'll have this recorded and post onto YouTube. So that's it, everybody. All right. See you next time.